Hello, welcome to the next video in the CCHP video learning series. Today we're going to talk about how telehealth policy is structured in the United States. Before we begin, a few disclaimers. Please know that any information provided today should be considered strictly informational. It is not legal advice. CCHP always recommends that you consult with legal counsel if you are interested in a formal legal opinion. And also, if I happen to mention some type of company or show a product, know that neither I nor CCHP has any type of financial arrangement, relationship, or affiliation with such a company. Center for Connected Health Policy was established in 2009 as a California telehealth policy organization underneath the Public Health Institute. We became the federally designated National Telehealth Policy Resource Center when we applied for a grant through the federal government through HRSA, but we still continue to work with a variety of partners on other types of telehealth connected projects, and those are just a listing of some of our partners that we work with. Some of the projects that CCHP does is we do a 50-state report on all the state telehealth laws, Medicaid policies, and regulations. We also act as the administrator for the National Consortium of Telehealth Resource Centers, and we are the convener for the California Telehealth Policy Coalition. So the National Consortium of Telehealth Resource Centers are made up of the 14 grantees underneath the Telehealth Resource Center program. What this is a federally funded program where each recipient provides technical assistance related to telehealth. There are 12 regional resource centers that cover specific state, and they operate as the program level, on the boots level type of technical assistance that people may need. How do you start a telehealth program? What do I need to consider? How does workflow work? How do I engage with patients? And then there are two national programs. The center is the one on policy, and there is one on technology based out of Alaska, but all 14 work very collaboratively together. I like to say you reach out to one telehealth resource center, you're actually getting all 14 of us, because if you ask them someone a question, if they don't know the answer, they consult with the other 13, and for the most part, most of the time, somebody will have an answer for that question. I mentioned that CCHP does a 50-state report, so we track all the Medicaid policies, laws, and regulations related to telehealth for all 50 states and the District of Columbia. We also track it on the federal level as well. So that is a snapshot of our website. We put that information for the states up there. It is publicly accessible. You can click on any state there in the map, and it'll bring up the information for that state. And we keep this regularly updated. So the information that is on the website is good up to February 2020. Now, it does not include the COVID-19 information. We were actually in the midst of our spring update when COVID-19 hit. We went forward with the spring update, and we have like the established in-law policies up through February 2020. There is on a separate section of our website the COVID-19 temporary changes, and we did that deliberately because a lot of those COVID-19 changes are temporary. They have not, for the most part, they have not been made permanent yet. When they are made permanent, we will update the map, we'll update our federal policies as well, but for now we have the two in separate locations just to avoid any confusion. So as you all know, COVID-19 has dramatically changed the landscape for everything, but particularly for telehealth. And a lot of questions that we get is, why is the United States so confusing with their telehealth policies? And there are several reasons for that. One of the biggest one is being that we have these separate systems in how we deliver healthcare and the rules that apply to them. So just sort of broadly speaking, we have basically two areas where you need to consider the policy. You have the federal policy and you have the state policy, and they each have their own sections of what they deal with. Now, they may deal with the same topic, for example, what is paid for, but they may deal with different programs that handle those payments. So for example, on the federal side of things, for reimbursement, you're talking about Medicare when you're talking about telehealth policies, but when you're talking about the states, you may be talking about Medicaid or commercial payers. So the way that it is set up is it's really this patchwork quilt level type of landscape of policies for all 50 states and the District of Columbia, and then you also have something else that's totally different. That's what's going on at the federal level. And then you have another layer of complication. You're not only talking about these separate jurisdictions and how they handle telehealth policy, but then you need to examine the policy itself. And the policy itself is like an onion. there could be a lot of layers to it. And then there are different policies and like how they impact a particular issue. So we'll show you what I mean by that as sort of like an example. So take something with federal law. So you have like this one entity that has some sort of telehealth policy. It's federal law. They put it into their statute, and then it can address different issues. It can address what's going on with telehealth and Medicare. It can address how you prescribe using telehealth, and then like maybe how you protect somebody's, health information. Those would be HIPAA, and then other rules like such as Stark, which dictates how you do contracting sometimes when you're receiving federal funds in some way. And then you take one of these and you like divide it up into like, how is that policy implemented? So you have federal law telling Medicare, this is how you deal with telehealth policy. And Medicare takes that law and they say, okay, we have to do certain policies around it. They're going to be regulations. So they go through this process called the regulatory process where they publish like their draft essentially of like what they want the rules to be to implement that policy are going to be. They take public comment and then they adjust sort of the draft and issue like a final regulation. But then you have something that's going on internally. It's like, okay, now we took those regulations, how do we implement it internally within the program itself? As far as the regulations say like you can bill for X, and then the internal policies of Medicare say like, okay, and this is how you bill for it. You can bill for it on this form, put this on this line, etc. So an example of that here is you have what's in federal law, the Social Security Act, and it says the secretary shall pay for telehealth services are furnished via a telecommunication system. So that's very important. That's what's in federal law, is that term telecommunication system. However, you go through the regulatory process, it suddenly kind of changed a little bit. There's now that word interactive telecommunication system before telecommunication system, and it changes the meaning of like what that means. So you had the law saying like you need to deliver a service through a telecommunication system. Didn't specify exactly what it was. It was just sort of some telecommunication system. But when it got down to the regulations, Medicare said it had to be interactive. So they put another word there. You had like another layer of the onion that may cause a little bit more challenges in like using telehealth or maybe narrowing the scope. Take this to state law. So you have state law, again, you have different areas in which, they may be directing things to happen, such as Medicaid or prescribing or privacy, or like boards, what boards may do, licensing boards, because that's within like the states to say as opposed to like federal law. Then you go through the regulatory process, and then you have like perhaps like different agencies that may be involved in one person's care that may have conflicting policies within their inside their agencies. So the example is state Medicaid program reimburses for therapy or behavioral health services for treating opioid use disorder through live video. State regulations may say, well, for drug treatment, you need the group therapy to be in person, as opposed to being able to do it via live video. And then you may have a licensing board say like, well, we're the licensing board for psychiatrists, and what we say is that the first visit needs to be required in person. And then you have counties that maybe run the drug treatment programs, and then they have their own rules to it. So again, like multiple layers going on with the policy that can impact the utilization of telehealth, and one reason why the landscape for it is so complicated. So what are some of the telehealth policy areas where we see this happening? So you have reimbursement, that's the big one. Then you have licensure and credentialing, prescribing, privacy and security, malpractice, and also, where it can impact during COVID was the lack of inclusion of telehealth during national and state emergency policies. That also, leaves it a little bit open-ended on like what the policy might be. So these are some of the policy areas that, we've seen things happen, especially during the last couple of months. We're just going to take reimbursement as an example to show you like, how complicated it can get. So a lot of the existing telehealth policy that's out there, the stuff that's on the books, is related to reimbursement. What gets paid for if you use telehealth? And then that reimbursement policy has 4 elements, 4 typical elements that you see over and over again in the reimbursement policies. It's the what, where, who, and how. So it's basically what service are they going to actually pay for if you use telehealth, where's the patient located when the telehealth interaction takes place, how was that service delivered, what modality was used, and who is the provider providing that service. So you take that and you break down like a telehealth reimbursement policy, and you can see these 4 elements are readily apparent. So for example, I'm Medicaid, and I will reimburse for what? Behavioral or telemental health services, where when the patient's located in the provider's office, how through live video, when or who, when it's being provided by a psychiatrist. So those are like your basic elements that you typically see over and over again in telehealth reimbursement policies. To show how it can get complicated, so Medicare, one program, but even they have made things a little bit more complicated. They have like 2 buckets of like how they reimburse and what they will reimburse for services when you use technology. They have their telehealth bucket, and then they have their tech-enabled communication-based services bucket. So your telehealth bucket are services that they are saying are being delivered via telehealth, and it's sort of a one-to-one replacement. Those services are basically taking the place of something that you would do typically in person. So it's like a switch out for an in-person service. It's delivered via telehealth. It's very narrow when you compare it to like, all the things that you can do underneath Medicare. It's very specific in services. Before COVID-19, very specific what type of provider can provide that services, specific on how you deliver services, the modality. And again, before COVID-19, very specific on where the patient had to be in order for that services to take place. So that is like, a lot of that is the reason why it's restricted is because that's what's in federal law. And then you go down the stream of like policy development, and this is what Medicare has come up with. And that's your pre-COVID-19. Things are a little bit different now with COVID, but that's sort of the policy structure of it. Then you have this other bucket of delivering services when you're using technology that Medicare is called tech-enabled or communication-based services. So those are services that use telehealth technologies, but Medicare does not call them telehealth because there's not that sort of one-to-one replacement with an in-person service. They're saying because the technology can do this now, there's sort of like no comparable in-person type of service for that. So we have this other bucket of services called tech-enabled or communication-based services that we will pay for, and these are the services. Now, they don't have the typical telehealth restrictions, and because they're not telehealth, they don't apply to these services, but Medicare has set up like other types of parameters around them. So, for example, what type of patient would qualify to receive the services. So one of them, like chronic care management, the patient would have to have been diagnosed with 2 chronic conditions or be a risk at hospitalization or death. So something like that are like the other sort of like limitations they may put on it, but they're not facing the same limitations that telehealth face. So again, where you can kind of see policy getting very confusing and very intricate because of like how they've structured it internally within the program. So on the state level, again, you see like a wide variety among states and even just what they do in the Medicaid program. It's not like they're all the same. You have live video, like being the most prominent type of modality that's reimbursed, and store and forward and remote patient monitoring less prominent, but you see like there's that diversity because it's not 50-50-50 across all 3 modalities. It's 50 in DC here, it's only 16 for store and forward, it's only 23 for remote patient monitoring. Then you have the other wrinkle of commercial payers and what they're required to do. And again, it varies from state to state. So there are something called private payer laws related to telehealth. And this is a law that a state has passed telling commercial payers this is what you do in regards to telehealth. And they vary. They range from all the way from a law that says you can cover telehealth services, health plan if you want to, all the way to a state that may have a law that says you shall cover telehealth delivered services health plan, same way you would have had it been delivered in person, and by the way, you'll pay the same amount, and then everybody kind of falls in between there. Again, creating like this very intricate different landscape, especially if you're moving from like state to state or you're dealing with multiple states. So this is just an overview of some of the policy changes that have happened during COVID, and you'll see like a lot of them fall into some of the categories that I mentioned earlier, like modality or like, location of the patient, the site location, the provider list, eligible services and everything. And this is just like an overview of what's going on at the federal level. And you can kind of see that there are similarities in like areas that they've addressed, but this is just, like I said, an overview. Once you start digging down deep into it, you'll find it's much more complicated, it's much more nuanced, there's a lot of details involved. But you can see at least the major areas that they all have in common are the ones that I had just gone over a few moments ago. So what do we expect in like the post-COVID-19 world? So a lot of these waivers, as I said at the beginning of this talk, are temporary, and a lot of them have expiration dates, or they may say like when the public health emergency is declared over, and that's where a lot of people are asking, well, when does that happen? And nobody quite knows yet. There doesn't seem to be like any hint of a specific date, although people are starting to be very concerned about like when is that going to happen, and policymakers too are talking about that, because what they want to avoid is like that cliff effect of like having all these waivers suddenly go away and people are left like not sure what to do, because do you take away all the telehealth relaxations? I'm going to say like that probably will not happen. We will not revert back exactly to our pre-COVID-19 world, but the question is what's going to stick around. And we're starting to see that discussion happening. Last week there was a Senate Help Committee meeting on this regarding telehealth and what should stick around, and at least members were signaling that they were interested in keeping certain things around, such as allowing the home to continue to be an eligible registry site. Those are good things, because if you're talking about Medicare, some of those will require congressional action in order for that to happen. So that's a good thing to see. Another thing to be aware of is like there are some things that CMS, at least on the federal side, can do administratively. That means CMS does not need to go through Congress. They can make the decision themselves. And probably where we may see some of that will be next month. So every year there is something called the Physician Fee Schedule Proposal. So this is a big set of regulations that CMS publishes every year for like the following year, saying like these are going to be the policies taking place for like the coming year. And they usually publish those in July. It was a little bit late last year, but it still, I think, occurred in July. And then the public has like a certain amount of days to like provide public comment on. CMS can take those comments or leave them, they adjust, and then they publish a final version of those regulations around October. So, and then they go into effect typically January 1st of the following year. So that's something to be on the lookout for over the next couple of weeks, because we then might see indications of what's going to be sticking around permanently. On the state level, we're already starting to see some states uh, implement or keep or make permanent some of the changes that they made temporarily in response to COVID. We're seeing legislation where there may be including audio only now in their definition of telehealth. We're seeing Medicaid programs saying we're going to make X permanent. And we're seeing commercial payers also saying like we're going to keep the changes that we made in reaction to COVID as a permanent change. I believe Blue Shield Blue Cross in Tennessee did that about a month or so ago. They made the announcement that they were making what changes that they made in reaction to COVID permanent. So we are starting to see at least some of these things we know will be sticking around, but it is still a bit piecemeal. We're not quite sure what the overall landscape is going to be. So that would be the question, is that, what's our onion going to look like in a post-COVID-19 world? Are we going to have like the picture I showed earlier where you saw a whole variety of different onions there, or are we going to have like kind of more common onions? Are we going to still have the yellow onion be like more prevalent than like, a bunch of different varieties? It's still going to be an onion, so there's still going to be like all those layers as well, but we may see a little bit more consistency across the jurisdiction as far as, certain things like services that are covered, certain providers who are allowed to provide services, where the patient's located, and the modality that's used. But that is something that we don't quite have the exact picture for, but I think it'll start developing over the next couple of months. So just a couple of resources that you have, like if you're interested in like all the COVID information, those are the links to our website. You can also subscribe to our newsletter, in which we will publish information or send out information as it becomes available to alert people. And we also focus in on like, specific issues that impact telehealth as well. So thank you very much. I hope you enjoyed this talk, and I hope it's a little bit clearer for you in how the telehealth policies in the United States are structured, how they work, and why it's so confusing. It probably will still continue to be confusing for a lot of folks, but as I said, hopefully like we'll have less variety of onions. It's still going to be an onion with a lot of layers, but less variety of them, so there might be more consistency once we get through at least this initial phase of COVID. So thank you very much. I hope you stay safe and have a great day.